Okay, so we can start now. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Most welcome everybody for this session, with our Professor Ahmed Mostafa, who is a well-known glaucoma specialist, international figure in glaucoma actually. And as you saw in the announcement, he has his own techniques and innovations in the practice of glaucoma. We are delighted today to hear from him and to learn from him about the complications of the tubes. This is a continuation of the last session, which was last Wednesday. It was tube surgery, tube shunt surgery, and today he will talk about the complications. What's unique and very pleasant and makes me very happy to listen to Professor Ahmed Mostafa, despite I'm not a glaucoma specialist, is his way in teaching. He simplifies the matters very, very much. He gives the matters in a case-based, and the discussion is very simple, direct to the point, which makes it easy. And at the end, you will find yourself learning a lot of points. So most welcome, Professor Ahmed Mostafa, and the stage is yours.
Thank you very much, Dr. Mazen. I really appreciate your very kind introduction. Thank you very, very much. And my heartily wishes to you and the Sinjab Academy in all branches of ophthalmology. Thank you very much for the huge efforts. Welcome everybody. And I'll just share the slides right now.
Yes, we can see the slides.
Yeah, thank you. So if you just remember from the last time, we just mentioned some basic information on the valves. I hope just to touch upon those information as we are going through the presentations. So the first part, we're just covering the types of implants, and I was happy that some of the colleagues are using the Barvelt and what's similar. But here in the Middle East, we mostly use Ahmed glaucoma valve. So it is almost the valve we have in Egypt, and we have the Orolap, which is an Indian version of the prototype Barvelt. So today we'll just try to come across some of the cases, and definitely we'll have different opinions. There is nothing that's black or white, and always we have different. Every approach has its pros and cons. Now, I wish first of all to discuss that if we have, regarding the special cases, a patient who is pseudophakic, because I see lots of those patients in the literature. So this patient is actually pseudophakic and is having pseudoexfoliation, is having uncontrolled glaucoma. Then when we have such a patient, you really don't know whether the glaucoma was pre-existing or the glaucoma developed after the phacoemulsification, because as we know, phacoemulsification and extracapsular reduce the intraocular pressure, so that some of those patients are already glaucomatous pre-operatively, and they received only cataract surgery and they continued with their glaucoma. Anyway, this is the current situation, and I see lots of those in the practice. Definitely the etiology, a list of causes for this and a list of types for this could be open, closed angle, could be a result of the cataract surgery, could be pre-existing before. So at the end of the day, you are having this situation. I just would like to highlight in the study, which is the tube versus trap, because this was a study that was conducted over a long period of time, starting from 2004. And the study concluded the 5-year outcome when they compared placing Barvelt implants. And then I'm happy that our friend from UK will probably be commenting, because he's having the implant is probably a Barvelt implant. So they compared the tube shunt using a Barvelt to mitomycin trabeculectomy for patients with recurrent glaucomas, and a large proportion of those patients were pseudophakics. And then it was very interesting that the reduction of the intraocular pressure was a bit comparable in both groups at the 5-year follow-up, but the failure, the probability of failure was higher in the trabeculectomy group. So that the trabeculectomy group cases required more secondary intervention to reach the desired outcome. So this was the message. Yes, the end result of the pressure is almost the same, but the number of interventions, including placement of glaucoma drainage devices following the trabeculectomy, was higher in the trabeculectomy group. And the conclusion of this study is that patients who are pseudophakic, usually that they respond better to glaucoma drainage devices. Again, there is nothing that's black or white, but this was one of the landmark clinical trials which suggested the use of glaucoma drainage devices for the cases who are pseudophakics. So that it is just revision of the technique. In short, you know that I tend to place the implant at 12 millimeter through, and I place the tube under 3 tunnels. So this is the triple tunnel technique for implantation of Ahmed glaucoma valve, so that each tunnel is 3 millimeter, and the 3 tunnels are really connected, so that the tube all the time is lying inside the sclera. And then when I think that every tunnel is doing a certain function, so that the distal tunnel is keeping the implant from forward migration, the middle tunnel is keeping the tube on the conformed to the sclera, and then the last tunnel is adding more protection to the tube, and then I'm preparing the scleral flap for the tube insertion inside the eye. I used to use tunnels anteriorly, but I stopped because I think the implantation through the tunnel at the limbus was a bit difficult in my hand. So you can see that the tube is passing from one tunnel to the other, and then it looks like it's a long tunnel in the sclera. Then the pre-placed suture is very important, because when I place the scleral suture after I placed the implant, I found it technically difficult. Nowadays, I place the scleral suture first. So when the implant is placed 12 millimeter, it's far posterior, and this was a pseudophakic patient, and you can the tube coming behind the iris as well. So when you look at the conjunctiva and the tube, nothing is seen. So that the only part that is visible is the intraocular part of the tube in most of the patients, because the implant is very posterior. And the advantage of that is the Tenon's capsule posterior is very thin. So that that's why the incidence of the hypertensive phase and the incidence of high intraocular pressure following the implants with this way, I'm reporting it to be significantly less. Anyway, the results are being collected nowadays for publication. And this is the intraocular part of the tube. Again, the intraocular part should be parallel to the iris, and sometimes it's touching the iris. There is no problem. Adequate length, it's from 2.5 to 3 millimeter. And I tend to make it at half the distance from the limbus to the pupil. So this looks like this is relatively long tube, but if the tube is half the distance on the surface of the iris, I feel very comfortable and satisfied. So this is relatively short tube, especially if it is in the children. That would be a very risky tube. And following that technique, you can see that the bleb, the upper temporal bleb, is usually a huge bleb, and definitely this bleb decreases over time. But again, the filtration through the valve is huge. And then if your patient is pseudophakic, like the case which I have shown to you, you can go through the ciliary sulcus 2 millimeter from the limbus. You will use the 23 gauge needle, and you go straight behind the iris, between the iris and the capsule. Once you create this tunnel, you need to be as fast as you can, because the tunnel tends to close. And now the tube, I like this position very well, being very far from the cornea. So that was again the conclusion of the TVT study. Now, from the practice, when I have a patient who is pseudophakic and is having glaucoma, I examine the conjunctiva, especially the superior conjunctiva, very thoroughly. Now, if the conjunctiva is very good, again, you can do the technique that you like trab, deep sclerectomy, like the one I'm doing, or valve. So that again, the condition of the conjunctiva is very important. If the conjunctiva is a bit borderline, then will be in favor of the glaucoma drainage device. So I spent time examining the superior conjunctiva. Again, this landmark clinical trial have just added new piece of information that the glaucoma drainage devices are bringing better results when they are placed in pseudophakic eye. Now we can have this scenario, a patient who is one-eyed patient and he's putting this anterior chamber lens. Then this is definitely a kind of maybe a complicated surgery. You can see multiple iridotomies, and the pressure is high under all treatments, and the disc is severely damaged. So that actually we need to do something. And here will be the debate: shall I go for diode cyclophotocoagulation? Shall I go for a valve? Anyway, I thought he's one-eyed patient, and then the condition of the conjunctiva and the eye was not very bad. So why not to try to place a valve? But again, when I go for an eye like that, I need to think of the endothelial cell count, because definitely this is a complicated surgery. So, and I need to think, and the endothelium is less than normal, so that I need to put this into my consideration. So again, at the time of the operation, I tend to mark the area of the superior rectus and the lateral rectus, and I sit facing the upper temporal quadrant, and this makes this area approachable and makes the implantation easier, at least in my hands. And then diathermy. Good diathermy, we need good diathermy, we need good exposure, and we use the retractor, and we use the artery forceps to separate. Again, this was the pre-placed suture. I put it first before putting the implant, and I leave it like double armed, and then I cut it later on after I place the implant. But again, this is 12 millimeter, and there is, and the area posterior is nicely dissected to receive the implant. Then I'll go for a preparation of the tunnels, like what I do in normal. But again, you need to think here that if the patient is having anterior chamber lens, then where should we place the tube? Should we place the tube in front of the IOL? Should we place it behind the IOL and the anterior vitreous? Again, lots of debates. So using the my beloved crescent, and for the distal tunnel, I usually go from the cornea towards the optic nerve. I feel this direction is very helpful. This might be a relatively older video than the 3-tunnel technique, so this might be 2 tunnels. Let us see. But again, the principle of the tunnel and putting the tube inside the sclera is really very good. And when you master the tunnel, you tend to have the sclera overlying the tube relatively thick. You need to have a good sclera actually overlying the tunnel. Again, the second tunnel, so that all the tunnels are connected. The exit of one tunnel is the entry for the other tunnel. So again, going gradually for the last part, I don't usually, I make it like flap, but this was an old video where I used to insert the tube through a tunnel. I found the implantation of the tube through the tunnel not very easy. Might be, it needs a lot of training, but anyway, I didn't like to implant through a tunnel in the area of the limbus, because the direction of the tube was not so much under control. So again, I'm pushing the implant posterior, and the implant should go easily, should go without any kind of resistance. The sutures here are non-absorbable sutures. I know some of my colleagues are using absorbable, other colleagues are adding no sutures at all. But anyway, I insist on using the non-absorbable sutures, and then making the tube beveled. And then I need to, and all the time I'm thinking, where should I place the tube? First of all, making the tunnels, it's not difficult to have the tube passing under the tunnels, but you need to hold the tube almost from the tip, so that don't make it long. When you hold the tube long, usually the manipulation is not easy, as you see, but when you hold it near the tip, it's usually much easier to handle. Then I'll do paracentesis. In all patients, I do paracentesis and inject some halo inside the anterior chamber. And in this patient in particular, again, that was an old video, but I just would like to show you the idea. I was using the tunnel, but I stopped doing that because actually I was not in very good control of the direction of the tube towards the cornea. So I decided here that being an anterior segment surgeon, I like to go anterior, so that if a posterior segment surgeon might go through the pars plana, but at that time you probably need to do extensive vitrectomy. But here I'm just placing the tube, and then it's coming into the anterior chamber, and I can see that there is a space between the IOL and the iris. So why not to push the lens behind the IOL? The IOL is really fixed so that the tube will not make the IOL move forward and will not angulate it. So that again, I just got the tube, and then I'm trying to manipulate the tube to be under the IOL, and then I'll keep pushing towards the anterior vitreous. Definitely, those days I may go for a sulcus fixation. That would be easier for me. But again, this was a relatively old video. Now, if we place the tube in the pupillary region in a patient who is relatively having the vitreous cavity connected to the pupillary region, there might be vitreous which should not be visible all the time. So the vitreous is transparent, and you might not see the vitreous strands. And for that, we need to inject quinacort inside the anterior chamber to stain the anterior vitreous and to see if there are vitreous strands or not. So this is a routine part, and you will see later on, if you miss this step, you can have vitreous coming through the tube and blocking the tube. So again, I'll inject diluted quinacort. It has a kind of anti-inflammatory effect at the same time, but in the first place, it will help in the visualization of the vitreous. So again, you can see lots of vitreous behind this anterior chamber lens. And this might be one of the reasons why this patient developed glaucoma, because the anterior segment is really filled with vitreous. So again, I'll go with the oculotome through the pars plana to have good control on the cleaning of the vitreous cavity. And I spend time going down to the mid-vitreous. If someone would like to do a complete vitrectomy, still okay, but for an anterior segment surgeon, I remove down to 1/3 of the vitreous. And then you can see that this patient is having clear visual access, relatively long tube that's passing behind the lens, and the pressure and the visual accuracy are really very nice. And this operation has been done like 3 to 4 years, and the patient is stable. So that I'm quite happy with the outcome. But again, still there is no black or white, so that someone might go for diode cyclophotocoagulation, someone might go for pars plana implantation. Again, that's the technique that I have done. So a young patient is coming for cataract and is having cataract and glaucoma, which is not very common at the age of 30 years. So that I decided to examine the angle of this patient, and then I realized that the patient is having angle recession. The patient is denying history of blunt trauma because the patient might have forgotten that he received a blunt trauma. But at the end of the day, this patient is having angle recession, extensive angle recession, together with glaucoma. So the best treatment option in angle recession is still not settled. But I planned here to go for cataract surgery and combine this cataract surgery with valve implantation. And to do that, I expose the upper temporal quadrant. I prepare my 3 tunnels. And again, with time, you get used to the tunnel preparation. And again, counter pressure on the sclera helps to get the knife out of the tunnel, because sometimes it keeps going inside the sclera. And then this will be the 3rd tunnel. Again, all the tunnels are connected, and the last one will not be a tunnel. That's why what I'm doing nowadays is not a tunnel, it is just a scleral flap. So I'm just enlarging it a little. It looks like that of trabeculectomy or a deep sclerectomy flap, but I dissect with the crescent as usual. and then I cut the edges. You can cut the edge, or for me, I can make it like a trapdoor incision. I can cut one edge, or I can cut both and make it flap, which is really what I'm doing nowadays. So again, I prime the valve, and again, priming should be gentle, not very extensive. And then while pushing the valve, take care not to play with this area. This is the area of the valve, so that we do not touch this area. This is a no-touch area, but I try to be around and then push the valve. If the valve doesn't go easily, I get it out and I keep dissecting. And then again, one tunnel is connected to the other, coming from one tunnel to the other, like the dragon technique. By Dr. Obaida, he commented on this last week. So again, while doing that, again, I am a minimum of 12 millimeter. And then this suture, it is not pre-placed, but nowadays I shifted to the pre-placed sutures. A minimum of 12 millimeter, sometimes it's even more. And then I'll place the tube again inside the second tunnel, just the tube will not obscure my my eyes at the time of cataract surgery, so that now I'll switch to cataract surgery, then I'll place my tube, and the results were really very satisfactory. So generally speaking, the summary of the first lecture, that my personal results have dramatically improved after I place the implant posteriorly, a minimum of 12 millimeter. Then after I'm tunneling the tube so that I don't see the tube, so that it's like a few years and I don't have scleral erosions over the tube or tube exposures, and the intraocular part of the tube is away from the cornea, is towards the iris. And by following these three principles in my mind, definitely I love the glaucoma drainage devices so much nowadays, compared like the situation like 20 years where I hated valves because I was doing almost the opposite in everything. So I don't like those appearance when the valve is very anterior. Now let's go to this interesting patient, one-eyed doctor. He's an Iraqi doctor. His pressure is not controlled. He was ophthalmic, so you can see half stripe. And I'm so happy when I see a survival of ophthalmos. He is 42 and he's having cataract, as you see, and the pressure is suboptimal. And he had an implant here. But as far as I can see on the slit lamp, the implant is very near to the back of the cornea, so that I need to think what kind of help I can offer to this patient. Again, I'm not satisfied with the tube. It's not very obvious here, but again, the tube is very near to the back of the cornea, and the cornea is not very friendly, as you see. So I discussed with the patient that we need to go for cataract surgery because this is expected to give him some improvement. And then I'll place the lens in the back. Cataract surgery was not difficult. The visualization was not bad. And then I'm going to trim this tube because he is now 42 and I don't think this tube will retract. And I didn't like the relation of the tube to the cornea. So again, I'm injecting mitomycin. Again, I don't do so much needling of the implant, but for this patient in particular, I try to inject mitomycin and to needle the bleb, and then I'm doing a kind of flushing the tube from inside, trying to get a better outcome. And definitely this was the first step, and I'm discussing with the patient, this is a trial. I'm not quite sure that is going to work regarding the pressure control because I don't do this on my valves. But anyway, I was so happy that post-operatively, the tube is seen here and the cornea looks slightly better, and the visual acuity of this patient is 0.4 and the pressure is beautiful. So that again, there is no black or white. You can think of something else. You can put another valve inferior, but I try to give this valve a push. And at the same time, I try to add more protection to the cornea by shortening this valve. Now, this is one of the very difficult situation that I faced. A patient with chronic angle closure glaucoma. The current status now following angle closure glaucoma is that we do phacoemulsification. Yes, we remove the lens. He's one eye, by the way. And then I removed the lens and I did this patient goniosynculisis. And the patient actually had an old trabeculectomy. This is probably an old trabeculectomy, and I'm happy that the iridectomy is lost. So the patient again underwent cataract surgery. I tried to open the angle more, and the patient came with a pressure that was not controlled. It is not common for a patient with chronic angle closure glaucoma, by whatever procedure you added to cataract surgery, to come with a terribly elevated intraocular pressure. You can still control with medication. But for this patient, the pressure was out of control. And then I decided to implant this patient. When we place implants in eyes with chronic angle closure glaucoma, there is a kind of technical difficulty because the orbit is relatively small, like the eye. So that the implantation was not a piece of cake, was a bit difficult. But at the end of the day, I placed the implant and I placed the tube in the ciliary surface and it was visible. And then the patient comes in the next 2 days after the operation with this picture. The pressure was terribly high. There is a blood clot occluding the pupil, and there is an area of mild hemorrhage probably coming from the site of the valve implantation. The anterior chamber was very shallow. And then again here, we need to think, there is no anterior chamber. Then we need to think what happened to this patient. Is it a pupillary block? It's difficult to be pupillary block because the patient is having a large iridectomy, as you see. So it is not a pupillary block. Could it be malignant glaucoma? I thought, yeah, probably this is a malignant glaucoma because of the uniform shallowing of the anterior chamber, because the iridectomy is patent. So what happened to this patient, unlucky patient, that he developed a malignant glaucoma following the implantation of the glaucoma drainage devices. This doesn't happen with open angle glaucoma. I haven't seen it with the open angle glaucoma, but it happened with chronic angle closure glaucoma. And I place implants extremely infrequently in eyes with chronic angle closure glaucoma. Anyway, this was the situation and we need to do something. The patient is just in front of me and the pressure is in the 40s. The patient definitely is having advanced damage, and you can imagine what is the level of vision at this moment and what is the psychological status of this one-eyed patient. So I told the patient that I'm thinking of that diagnosis. Let us try to make use of this iridectomy to do YAG hyaloidotomy. So I'll go with YAG. I'm happy that the YAG machine is next to me. And then I tried to open the posterior capsule, the whole capsule, and the anterior hyalot. Okay, and then I did that, and then I left the patient for like a couple of hours in the clinic, and I realized that he's getting better. So that I started to feel relieved. I sent the patient and asked him to come a few days later. And then what happened? That the anterior chamber started to reform and the blood clot started to dissolve. And the pupil, part of the pupil is seen, and the patient is now coming happy. Of course, he's having a tubular vision, but now his vision come back, or at least it doesn't come back fully, but at least much better than the situation that we had. And then the AC, as you see, started to reform. I was so happy for that. And then some inflammation inside the eye that is resolving all the time with heavy steroid. And then what I did, now you see that I'm sure that I put the tube under the iris, but I don't see the tube. And I would love to see my tube. So what I decided to do is that I know the place where the tube is. I'll do YAG iridotomy over the tube. And I was happy that the tube was delivered through the iridectomy, and then the iridectomy closed behind the tube. That was really very touching to me, that I could manage this patient to that way. His pressure is 12, his vision is 0.3. He's really happy. And the whole miss, this was like a couple of years ago, and the situation is persistent like that. So that he's having like some synecdoche, but the eye is quiet, and then he's seeing very well. So again, the message from this case is that patients with chronic angle closure glaucomas are really difficult to implant. And I have seen this complication of malignant glaucoma, which is what was confusing is there was an hyphema occluding the pupil at the same time. So that makes the diagnosis very confusing to me. And then if patient is having iridectomy, we try to make use of this iridectomy by doing YAG procedure, opening the capsule, opening the anterior hyaloid, and this can resolve an attack. And again, still YAG iridotomy over the tube is something good, so that now I can see the tube. I'm happy with that. And this picture is now for a couple of years. The patient is happy, and I personally feel very happy. And every time I see the patient, I would like to take him to the camera and have a photo. Anyway, I'm very thankful because the operation ended like that after the complication. And that's the situation. The tube is away from the cornea. And that's the picture, one of the latest picture. The eye is very quiet. The cornea is very friendly. And then some patches. That was an area of iridectomy that healed after delivery of the tube. Sometimes you make decisions to do cyclophotocoagulation. And I think all of us had that. We did cyclophotocoagulation, and then you feel that the visual potential is very good and you need to implant this patient, especially for one-eyed patients. Or the patient had received cyclophotocoagulation somewhere. Now the patient had marks here. So the question here is that to change the decision from cyclophotocoagulation to a valve, this is not an easy change, because post-operatively the patient can develop hypotony because the ciliary body is already borderline, and then if there is increased range, can get hypotony. Anyway, after dissecting the scleral flap, you can see the spots of diode, and the implant is 14 millimeter. By the way, following this technique, I have very small pieces of remnants of the valve. So again, I'll implant the valve. We go parallel to the iris. It's very parallel or even inclined towards the iris. We use 23 gauge. We can fill this needle with helium, or we can inject helium from the side port. Anyway, this area is better to be deepened by helium, and then the tube will be placed. And then if your patient is having this thinned out sclera, then you can think, is there a necessity for something to cover the tube or not? Because under normal circumstances, I just suture the scleral flap, and I'm very happy with that. Do I have to cover with something? Do I have to use a scleral patch graft, Tutoplast? For this patient, I fashioned the scleral patch graft because I feel the sclera is relatively weak. So why not to go for a scleral patch graft? It will add extra safety to the procedure. And as you see, the patient had failed a glaucoma surgery before. Now, this is another point of view, that sometimes we need to have extra length of the tube. This extra length of the tube, you can observe intraoperatively. Now, I'm preparing for the implant. I used to put some marks, and then I'm placing the tube. And unfortunately, I'm not very satisfied with the length of the tube. And I'm still inside the OR. So what I have done, I just went back to the sutures of the plate, and then I took the sutures at a more anterior location. So it was possible to do place advancement while still intraoperative. I don't have to close everything. And then post-operatively, I realized that the tube has retracted. No, I still have something to do here, which is to re-advance the plate. And that's what I have done. So I'm placing new sutures in one of the eyelets. And again, I'll cut this one, and this will give me like a 2 millimeter, which will be very advantageous to the part of the tube intraocular. So that was my management to this difficulty that I faced intraoperatively. You can see some vessels here, so try not to touch some choroidal or vessels under the sclera. So again, after doing that, you can see the tube is now convex. I can push the tube and get an extra length of the tube inside the eye. So now I feel definitely much more satisfied. Now, the problem is that this could happen post-operatively, especially with the kids, when the tube retracted. For Ahmed glaucoma valve, the new medical world have produced this glaucoma tube extender, so that you will connect the remnants of the tube here, you will fix this to the sclera, and then you will put this part intraocular. The problem of the tube extender is actually multiple difficulties. First of all, it is expensive. It's around 200 US dollars. Number two, it is not available. It's not available, at least in Egypt here. And thirdly, it is very bulky. So that most of the glaucoma surgeons, they don't like it because it's very bulky. So for that, I know this is a simple method for lengthening the tube using Ahmed glaucoma valve. And with this technique, you will see that this is an adequate length, but for babies especially, you can have the tube that retracted. So what I thought of, this is a piece of Ahmed glaucoma valve, and that's what's new. It's a piece of Ahmed glaucoma valve. Then I will take McPherson, and then I will thread the tube over the McPherson. The aim of this is just to open up the lumen of this piece. And then I will take if this is the valve, the shortened tube, I will just put it inside, and then I will slide, and then the two segments are quite connected. And then they are patent, so that it doesn't mean they are having the same diameter. No, look, it's very strong. It's not easy to remove them from each other. So in some patients, actually, we don't have tube extender. We don't have to buy another valve. Then I'll get the tube out of the eye, and then I'll get another piece, an old piece of Ahmed valve. And then now you can see the tube is becoming large. So this is very economic. And they are of the same diameter. But again, if you open with McPherson, you can get an extra length. And it doesn't occlude. Searching the literature, I found what's known as tube-in-tube technique that was published the last year, tube-in-tube technique by a group of surgeons. They used a tube from Orolap, and they placed it on Ahmed valve. The tube of the Orolap was slightly larger, and that's why they suture this junction using 10-0 nylon without getting into the lumen. So this is the tube-in-tube, but using, now I'm showing that I'm using the same piece of Ahmed glaucoma valve with the same diameter, and the tube, the lumen is not occluded at all, so that you can give an extra survival to the implant without having additional cost to it's very economic. But the point is, with my technique of placing the valve very posterior, it is very uncommon to have enough length of the tube that is left for other patients. Anyway, it is a solvable situation. And this is the picture years after the operation of the extra length, and the conjunctiva was nice. Definitely you can have, again, there is no black or white. You can think that why not to put another implant if this is a very fancy luxury management, but again, it is not always possible, especially when the patients sometimes have to get the implants themselves. Now, in this case, this is an interesting case of a one-eye patient, and the patient is having iris claw lens. So this patient is underwent cataract surgery and is having iris claw lens for correction of aphakia. The patient is having a tube, and I put this tube months ago. But the patient comes with the pressure that was elevated. And then I thought that the tube would be obstructed by vitreous. Took the patient to the OR, and I'm injecting diluted triamcinolone to see how the tube is occluded by the vitreous. And then I'll realize that there are lots of vitreous in the anterior segment. So that I'm just reminding you that this was my patient in the first place, is having uncontrolled glaucoma. But what happened is that I did not do good vitrectomy in the first operation. So the vitreous under the reduction of the intraocular pressure moves forward. Now I'm trying to clean everything, and then I'll go as back as possible. You can do like 1/3 of the vitreous cavity, and the tube is here lying behind the iris, but the tube is still surrounded by lots of vitreous, which I did not realize during my first operation. So the tube could be obstructed by vitreous in the patients who are aphakics or pseudophakics, and then you did not recognize the vitreous. So again, the tube will start to show. Now the tube is free from the surrounding vitreous, so the tube will be visible. I make sure that no vitreous in the tube, and then again I inject triamcinolone 2 and 3 times, and then I try to move around to clear any possible vitreous debris. I re-inject again to make sure that there is no vitreous, and this patient is now having a controlled intraocular pressure. But again, I was just wondering why my patient got the pressure that was out of control, because the tube was blocked, and I did not use triamcinolone to stain the anterior vitreous and to make sure of that. Again, the situation is different. Everything is clean. I'm putting air bubble. Then I'll show you the first operation. What was the mistake? And that was like months ago. At the time of placing the implant, again, I'm putting Helon, and Helon would push the vitreous, and then I'm having the tube. I'm placing the tube through the cilia sulcus behind the iris claw lens, and then the tube is coming, and I did not realize that there is a vitreous obstructing the tube, or I thought that the patient had enough anterior vitrectomy before, so that I did not stain, and that was the mistake. And even if you think that your patient underwent proper anterior vitrectomy, you need to stain to make sure that no vitreous that will obstruct. Now, this is a nice case for a patient who is having a movable implant. As you see, if the whole thing is moving, so that probably this patient was sutured by absorbable or non-sutured at all. I really don't know. But we need to, but I need to fix this because it's coming, it touches the cornea. So I told the patient that I'll go for trying to fix this this valve. So again, it is very mobile. You could just, simpler solution, you could just cut the tube and think of some other option. But again, here I decided to solve the problem from its root. Now, this is the valve. I'm trying to cut of the fibrous capsule. And then this is the capsule that I was talking about in the last lecture, that this is fibrous capsule, and the permeability of this capsule will control the level of the intraocular pressure. Now I can see the valve, and you can see that the holes, the eyelets, the fibrous elements are going through the eyelets. And that's why the valve is having some holes posterior to allow chance for the fibrous elements to go through. Then the valve is really very anterior, and the valve is very mobile, as you can see. So there is no way to deal with this valve in this way. I need to prepare a good place posterior, so that no way to push it posterior. It is just, it is very anterior. Again, a lot of resistance. So I'll just cut. I want to, again, I want to preserve the valve. I didn't have another valve for this patient. So I'll just try to preserve the tube, and then I'll cut this fibrous capsule. Again, putting some Helon inside the eye, and then the valve is released. At this stage, the valve is completely released. It was the small design, FB8. And then now you can see for the first time, I can see the texture of the periplate fibrosis. So again, this layer is lying inside the capsule. This is quite different from the bleb of trabeculectomy, quite different, very smooth. And then the permeability of this Tenon's capsule or the periplate fibrosis will determine the flow of the aqueous through it. So anyway, I try to dissect posterior. Again, I'll try to find the space, more space, because I wanted to get the valve posterior. So I'm now underneath this capsule. I'll create another space, and then I'll push my valve here. And I was successful in that, actually. Now the valve will go. If the valve refuses to go, I'll dissect more. But the valve is getting into a better position. Now I'll put some non-absorbable sutures, and I'll put the tube again. I guess most of my colleagues have seen patients with tube exposure. This is not uncommon, especially if the tube is left under the conjunctiva without any protection or covering. So I have this is one of my patient underwent the operation here was done years ago. Okay, and this is another patient, and then you can see something is the tube is covered by some dirts here and a large part of the tube inside the anterior chamber, and the patient is getting frequent intraocular response, or frequent intraocular inflammation in response to what's happening on the ocular surface. So the patient is so much irritated from the continuous inflammation. What I'm trying to do is just to remove the necrotic tissue around the tube. Now, if there is a tube exposure, this environment is not healthy environment, lots of inflammatory mediators. We need to change this environment. We cannot just close the conjunctiva over this of the tube. No, it will erode again, it will expose again. So here I just removed the whole necrotic conjunctiva, and then I'll fix the tube because I thought now this tube was extraocular, there is no tunnels, there is nothing. And then this is actually not my patient, but I can see that the tube is almost on top of the sclera, and the tube is a large part. That's why this tube erodes, because the tube will be convex, eroding the overlying conjunctiva. So again, I'll put some sutures, then I'll put scleral patch graft. So there is some indication that you need to actually depend on some other tissues like the tutoplast, like the scleral patch graft, what's available and what you are used to. The conjunctiva was actually good because I was a young patient, a lot of conjunctiva, so that I will do a kind of release incisions to the posterior conjunctiva. When we do release, we cut the conjunctiva without cutting the tenons. So I found that the conjunctiva, it's possible to get an additional length of the conjunctiva this way. So just cutting the conj, not cutting down to the implant itself. And I was very fortunate that the conjunctiva could be directly closed after trimming the corneal epithelium, and I have got nice healing. And then afterwards, after I sutured the conj, I'll move to the tube because this tube is relatively long, as you see, and then I'll shorten this tube because the tube was long and was a bit close to the cornea. It's not difficult that I'll do a temporal keratome incision, and then I'll cut this tube. Sometimes during cutting the tube slides, so I can have fixation of the tube with something else. Again, I'm closing the conjunctiva, and you can see that the conjunctiva is, there is an ample conjunctiva. I'm so lucky, and the patient is actually lucky that if there is a shortage of the conjunctiva, that I need to search for grafts, but actually here I didn't have to do anything. The conjunctiva was very good actually, and it was closed by a continuous suture. Then I'll go for, after closing the conjunctiva, I'll go for a keratome incision and fill with healer. Again, the tube is near the cornea, and if the tube is near the cornea, you can always see some corneal opacity nearby. And then I did a direct incision, and then I'll inject Helon to fill the AC beautifully. And then I'll go with a scissor to cut the tube. Sometimes the tube does slide because of the Helon, and then I'll go with some other instrument. Here it was a repositor. It will fix the tube, and then it will give me a chance to cut it, because once I try to cut the tube with Helon around, the tube slides. But I found that when you do it something by manual, now the tube is shortened. I know that there might be some, I hope that the dose is not very big, but I would love to share with you this patient. This patient was done yesterday. The patient came with ocular irritation and he underwent valve, and you can see that the valve is actually very new, touching the cornea. The cornea is becoming opaque at the central part. The patient is PIX, pseudo-exfoliation, and he's pseudophakic. So the decision here that the tube quite long, very near to the cornea. The operation was done few months ago. And then this is the conjunctiva still irritated. Just to make sure that everything is good, I'll inject saline underneath the conjunctiva. I'll do hydrodissection of the conj just to make sure that the tissues are dissectable, because I'm going to manage this tube. Here, if I'm going to shorten this tube, the problem will remain because the tube is adherent, is very near to the back of the cornea. It's not being just long tube, it is tube that's on the back of the cornea. So I need to modify this. I need to change the direction of the tube. Now this is the incision line, the healed incision line. I'll try to go slowly. When there is an implant and I go with the scissor, we try to be extra cautious because we can cut the tube, we can damage the valve. It's a still blind approach to this moment. So all the time we need to make sure that we are not cutting the tube. Yeah, could we cut the tube? Yes, we can cut the tube. And then again, doing good diathermy, I want to have good exposure. And I'm thinking all the time that this tube should have another direction. Yes, I can cut it and then put another implant, but this is will not be an easy management as well. So again, side port filling with Healon. And you can see when you fill with Healon, the tube will move forward because the direction is towards the cornea, is not towards the eyes. Then I'll go gradually, cautiously, removing the layer of tissue. It was like a thin layer, it was not sclera, or was very thin layer of a sclera. So we'll try to slowly remove this layer. And at the same time, I'm preparing a second scleral flap so that I thought I'll change the direction of this tube into another scleral flap. The tissues, they bleed definitely because it's a bit inflamed eye. So I'm dissecting here a second flap nearby the tube, and then I'll go for release of the tube gradually. Yes, we could cut the tube, and then again using a fine repositor underneath the tube and to try to lift this tube out of the globe. And then gradually you need to release all the adhesions around so as not to cut the tube. I don't want to cut the tube. I would love to preserve this valve. So again, gradually trying to get the tube by manual, supporting with the other hand, and then gently applying traction. If there is a resistance, I just stop. And now again, the tube is coming so that I can see the tube now has come out of the eye, and the eye is filled with Healon. Then I'll trim this tube. And then my plan was just to place it through another entry site. Then I keep dissecting. And then I realized that my patient is pseudophakic. So why not to place the tube in the ciliary sulcus? Okay, as you know, as I have shown in the first place, we still can make use of the ciliary sulcus, but the lens is not very stable. The patient is pseudo-exfoliation, but again, it was possible to place the tube. Now, the tube here, I'm not sure whether this tube is in front or behind the IOL. It's a very confusing. So I went with the Sinesky. Now the tube is behind the intraocular lens, but the lens itself in a very, it's a decenter, but the pupil is narrow. It's a pseudo-exfoliation. The pupil is not dilated. So again, I'll do by manual. I'll push with one hand, and then I push the optic of the IOL, and then I deliver the tube in front of the optic, and then I pushed the optic back. Definitely, this is not possible to be done with the large optic lens or with a lens that's very stable. It is just the whole capsular bag here, because of pseudo-exfoliation, is a bit weak. So let me make use of this weakness in trying to get the lens in front of the IOL. Then I want to have adequate length. So otherwise, the valve might go behind the IOL. And what's the problem of the valve behind the IOL? There is a possibility of vitreous occlusion. So after this, I'll put some suture. I'm putting a suture on the tube. I want to have this tube because well fixed, because there is a large part of the tube that is exposed. And then this is scleral flap. There is no need for this scleral flap. I'll get a scleral patch graft for this part. And then finally, it will be used to cover the everything. And you can see the tube is now in the ciliary sulcus. And this is the opacity of the cornea that was due to the touch between the tip of the valve and the cornea. And those opacities, sometimes they resolve after improvement of the situation as I'm doing. The conjunctiva was really good, so that I was able to close the conjunctiva, and that was the conclusion of the surgery. I'll skip this case. This is a long case. We might have another third meeting for some other interesting cases. But again, and even this case, but I just want to say that generally speaking, I'm so confident at the valves nowadays, and even support their use once you feel that the trabeculectomy or whatever technique you are doing in the first place will not work sufficiently. On my personal level, when I placed the implant posterior, it was difficult because of to place posterior like 12 millimeter or 13 millimeter is not easy. But with time, you get used to that. And I feel the advantage of placing the implant in an area where the Tenon's capsule is thin, so that I'm not facing lots of hypertensive phases. And then by tunneling the tube into the sclera, now I feel safe when the tube is embedded in inside the sclera. And then the intraocular part of the tube is completely away from the cornea or in the ciliary sulcus in patients who are pseudophakics. And actually by following this, and I'm using the non-absorbable sutures to fix, because the case which I have shown, probably the valve was not sutured at all or received a kind of absorbable sutures. I really don't know, but I didn't find sutures. So again, I feel okay when the implant is fixed to avoid movement of the tube inside the cornea. So just simple principles that took my results to another area, motivating me for more glaucoma drainage devices once they are indicated. And with that, I thank you very, very much. I hope it's not too long.
Thank you very much, Professor Ahmed. It was really an interesting and nice cases you presented. I keep on hearing you until tomorrow morning. We will not feel. You hear me?
Oh yes, yes.
Yeah. It wasn't long actually, because if we keep hearing you for until tomorrow morning, we will be more than happy.
Thank you very much. My pleasure. Thank you very, very much.
So,
you know, Dr. Mazen, I still have lots of challenging situations. Okay, so we still have a third part in the near future, if you wish, inshallah, in a few months.
Of course. Thank you very much. So we can open the discussion now, and we will see if any of the audience has some questions. So let's start with our new guest, Ricardo.
Hello, Prof. Ahmed. Thank you very much for your very instructive lecture. And yes, you can go on until tomorrow morning. We will be fine. We will be still hooked.
Thank you very much. Thank you very, very much.
I really appreciate it, because being in the UK, I do have much more experience with bare valve tubes and with recently with pole tubes. But my first few tubes were actually Ahmed's. And I was wondering, do you use MMC with your tubes?
No. No. And actually, the cumulative, you know that there is a kind of debate in the literature, but I think the recommendation now is not to use mitomycin. However, at the time, there were some recommendations that you can use post-operatively. So you can inject in the close vicinity of the plate, even every day, that would modulate the inflammatory response. This is one issue. The other issue, there is also a kind of debate regarding the effectiveness of mitomycin regarding the periplate fibrous capsule that will develop. So that, and as you know, there is no black or white, some reports suggesting a little better results, others are not. But I guess in total, we are not, there is no strong recommendation or evidence-based medicine in favor of the anti-metabolites, at least intraoperative.
Yeah, well, I agree with you, because I've done a literature review recently, because I actually did a study on MMC on Berville tubes. And actually, in Ahmed tubes, it does look like the MMC makes no difference. But this study, which we're submitting at the moment, actually we've submitted, does show that with Berville at least, the MMC increases the success of the tubes in complete success, meaning with patients that are not using more drops, so any drops, the success is increased. And obviously, when we look at the patients with MMC and without MMC, we know that patients that did not have MMC used with Berville tubes need more medications to attain an IOP of lower than 18 milligrams of mercury. But that's with Berville, and that's actually the brunt of my experience. I also wanted to ask you another question regarding when you put the tubes in the sulcus, or when you put the tubes behind the iris. Do you ever do a iridectomy to show the tube? I know that you did one with a laser afterwards, but do you actually ever do it intraoperatively?
Actually, no, but I try to have a large tube that's seen through the pupillary margin. So this is my aim, but not to be seen through an iridectomy. But it happened with me at one time that a patient had iridectomy that I passed the tube through an iridectomy. Yeah. But actually, do you do that? Do you do iridectomy for?
Yes. Well, my training with tubes was to leave the tubes really short. To leave the tubes just about 1 millimeter to 1.5 millimeters from the limbus. And the way how I was taught tubes, sort of placing it behind the iris, was to actually put a little iridectomy where the tube is going to fall, and as well as you said in your lecture, to check it thoroughly with Kenalog or Kenacort, as it's called, that there's no vitreous, because that you save yourself a lot of trouble by making sure that there's no vitreous plugging the tube. Yeah.
And you do that with the oculotome after you place the tube? You use the oculotome for the vitrector?
So to the Kenalog, I'll just inject it. I'll take any vitreous with a cutter, and I'll also do the iridectomy with the cutter.
Oh yeah, interesting. So that this iridectomy should expose the tip of the tube. Yeah.
Exactly, just the tip of the tube.
Just in case you say, okay, interesting. Yes.
And it with the iridectomy, it basically shows the tube, so I can see it. It allows me to keep my tube a little bit shorter, which I like, maybe because of habit, but I like to have the tube shorter. And also it allows me to see where the tube is in relation to the implants. Yeah,
interesting. You do that in patients with the neovascular glaucoma, for example, as well?
Yes, I do, and I found no problems. I think that once you got the neovascular glaucoma sorted with enough retinal laser, maybe a couple of Avastin injections, the iris doesn't bleed.
Yeah, I see. So that if your patient is having a posterior chamber lens, then at this patient you do with the oculotome opening in the posterior capsule, anterior capsule, and iridectomy, or how do you do iridectomy in this?
So basically what I will do is that I'll just go with a cutter under the iris, turn towards me, and I'll just cut a little iridectomy. So basically, I'll use the cutter, and I don't use the cutter settings for vitreous, which is cut IA. I'll use the other which is IA cut, so that I can aspirate the iris and cut.
Interesting. Interesting. Thank you. You know, there is no black or white in every.
No, there isn't. There isn't. And that's why these are good. I had one third question, if you allow me.
Yeah,
which
please,
is for aphakic patients. When you do a tube and an aphakic patient, do you put an AC maintainer?
Look, I don't do tubes for aphakic patients. If the patient is aphakic, especially if vitrectomized, I don't like to open those eyes at all.
Mm-hmm.
The patients which I have shown having like iris claw lens, like anterior chamber lens, that's something to support. But at the time being, for aphakic patients, I go for cyclophotocoagulation. I'm not a big fan of opening those eyes at the moment.
Yeah. I think also what I did was, on my training, I did quite a fair amount of pediatric eyes that were aphakic and high pressure. So what I would recommend everyone listening is that if you're doing an aphakic patient, just do it with an AC maintainer, because you literally have one compartment in the eye. So as you say, there's no lens in there. So you need to keep that pressure to tamponade the back of the eye.
Yes. Thank you very much. Yes, thank you.
Thank you, Ricardo, for the nice questions.
Thank you, Ricardo. Yes.
Please stay with us, Ricardo. Okay.
Of course.
Yeah. And please ask more questions if anything came to your mind. Yeah, feel free.
Yeah. Meanwhile, I'd like to ask a question. One of the colleagues here placed it. Does the position of the tube behind the IOL, in your case, does it compromise the visual axis by tilting the IOL? Does it cause any tilt?
Yes, I just commented on that. Yes, I know this is a very nice question, but this anterior chamber lens was so much fixed, so that when the tube behind the IOL, it doesn't push the IOL forward, so that it doesn't tilt the IOL. This is number one. The second observation, that none of the patients complain of like floater or seeing some aberrations due to the tube, because it looks like being far away from the retina. Most of the patients, they do not feel the tube, although it is just it is in front of the pupil. So that to be honest, definitely it is just a gross observation, but I did not like measure the IOL with UBM and then pre and post and see if there is a kind of micro tilt that happened or not. But again, if I'm going to face this situation, sulcus fixation would be much easier.
Yeah, great. Super. Thank you very much. So no more questions, but let's listen to discussion from the colleagues. We will start with Ali.
Basil.
Thank you, Dr. Ahmed. Thank you for this nice presentation as usual. Also for Dr. Ricardo for the comment. But Dr. Mazen, for the question for the IOL, this is for Dr. Ahmed. I think only this is presented for the anterior chamber IOL. This is very hard on very fixed IOL. But if this is contact with any posterior lens in the posterior sulcus, this will affect the lens. Usually, if you touch any lens in the posterior sulcus, sometimes you find this is movable and very easy to move. For that, I didn't like to touch any lens in the sulcus. This is Dr. Ahmed. I think he presented for the anterior chamber lens. This is very, very hard on fixed. Maybe this will be easy on can push the iris posteriorly. But any lens in the sulcus, I don't think to touch. For that only, I like to implant the tube in the sulcus if I find there's a big distance between the iris and the lens. When I measure or see the lens, the pupil, with a small pupil or the normal pupil, you will find in some patient there is a big distance. In this type of patient, I can implant the sulcus. Otherwise, In the other group of the patient, you find the anterior chamber very deep, and also the lens beside the iris, beside the lens. In this case, the patient, the lens implanted in the sulcus, not in the back. This case, I prefer to implant in the anterior chamber, not in the sulcus.
I totally agree with you, Ali. You know that sometimes with the combined cataract and tube implantation, yes, I thought that the sulcus placement would be nice, but after I remove the cataract, you find the AC is very deep, and there is no need actually to go behind the iris. Definitely, the implantation behind the iris is more difficult than the implantation in front of the iris. So I totally agree with you, Ali. Not all the cases. Pseudophakic, it doesn't mean that every patient should have a sulcus tube. Yes, absolutely, totally agree.
One small comment. This is I prefer to with gonioscopy when I find any anterior synechia with the patient. When I make a gonioscopy and find anterior synechia in this area, you find this is the best area for implant the tube in the sulcus. And for this group of the patient, you find the pupil distorted in this area. On this area is pushed against the cornea. In this case, if you implant it in the sulcus, you have many advantages. You can see
space. There will be sufficient space.
And you can see the tube if you also implanted not so long tube to be seen in the pupil, because the pupil already distorted in this area. This is the advantage. On you also. And no touch for the tube with the iris. This is the advantage. On this kind of patient, the best patient to implant in the sulcus.
Dr.
May
Bassel,
I ask sorry,
Dr. Ahmed,
may I ask the group who of you is implanting in chronic angle closure glaucoma patients? Did you try this? Yes. Even after that, Bassel, so it's please.
Yes.
What's your impression?
I implanted it for many patients. It's easy if the patient eye is normal in total anterior posterior length, but it's very difficult when the eye is short, when the globe is short, because the anterior chamber will be shallow, as we know mostly. But if the anterior chamber is deep, in this case, maybe I find some difficulties in inserting the tube to the anterior chamber, but mostly I succeeded in put the tube in front of the iris. And for Alhamdulillah, I didn't face any problem with these cases. But I have a comment about surprises happened with us sometimes. Usually we are deciding to put Ahmed valve in complicated cases and to avoid post-op complications. So I will give this story for you. For a single eye young patient, 14 years old, he has a congenital glaucoma with 2 previous surgeries before. And unfortunately, his pressure is still high with the maximum medications. So I decided to implant for him Ahmed glaucoma valve. I did the surgery under general anesthesia, and the surgery was straightforward with no complications. And I finished my surgery happy and within time. And I expected to find a good result second day. But unfortunately, second day, when I removed the eye patch, I noticed that the anterior chamber is flat, no anterior chamber at all. The iris touching the cornea. The pressure is so high, and the patient can't see anything. It's really no one of us hope to see such cases at all. And I really astonished. What happened? I put Ahmed valve in a proper way, no leak, nothing happened during the surgery. I can't find any answer. I did a B scan for the patient, and the picture was black for any one of us to see a choroidal hemorrhage and kissing retina. يعني very bad situation. At that day, I called Dr. Ali in the evening if he remembered if he faced such cases before and what happened to the patient. Yani, it's unexpected at all. So we discussed about sometimes maybe because during the anesthesia woke up, something happened to the patient. Is it because the valve damaged, maybe during priming the valve, or because there is a problem in the manufacturing the valve? I Googled the case and I found some problems sometimes. Many cases reported that there is a damage in the valve sometimes happened and the valve lose its ability to control the pressure in the eye, and in this case it acting as a shunt without any resistance. Anyway, alhamdulillah, this patient treated by atropine, acetazolamide 3 times per day, systemic corticosteroid, prednisolone acetate 1 milligram for 1 kilogram, and topical eye drops. And the case improved gradually. And during 4 weeks, alhamdulillah, retina became flat, and we didn't find any reason to go for surgery for him. And he, the vision, the patient restored his vision again. So the message is sometimes things happened against our expectations, but we shouldn't stop. We have to manage, and we have to think what's happening with us. This is one case happened with me, and I really want to share this with you.
Yeah,
and if you, Dr. Ahmed, or other audience have any comment about this case, please to share with us.
Dr. Basil, I think we don't. Ricardo, would you like to comment?
I was just going to say that I think one of the secrets of getting success with chronic angle closure glaucoma, number one, is to consider trabeculectomy. They do really well with trabeculectomies, chronic angle closures. But if the patient is phakic, is to have a look to see, because some chronic angle closure glaucomas, when they're phakic, the angle opens very well. And in that one, I would put an anterior chamber tube. But if the space is a bit restricted, then I would definitely do a sulcus tube. And also, this also applies for nanophthalmic eyes, which is a completely different kettle of fish. But I think what I have to say is that I use the Berville tube, and not only I put a supramid suture in the tube, I also tie it off with a vicryl, so a degradable suture, because on the first 4 to 6 weeks, I don't want any posterior drainage from the tube. I want, because I use MMC, I want that posterior conjunctiva to sort of start settling. And what I use to control the pressure from the tube is that I put a 9-0 vicryl through the tube, through and through, that acts like a wick. And what happens is that I've got a very good control of the pressure, and on angle closures, it's less likely that the tube is going to overdrain. So that's one of the suggestions that I do, is maybe for angle closure where the angle is a bit tight and the anterior chamber is a bit tight as well, to use is it Auralab that you have? That it's
available around, but it's not in common use.
Okay. So I think maybe a Berville tube will give you a little bit more control of the flow, because you can tie it off. You can have no flow, and basically just have the pressure controlled with that 9-0 vicryl wick.
So that, Ricardo, do you go for trabeculectomy in chronic angle closure glaucoma as a solo procedure?
Yes, I find they do very well.
Interesting. That's another good
even
yes.
phakic patients with angle closure.
Phakic, yes, I mean phakics, yes.
I find they do very well. obviously, I'm not a big fan of doing filtration surgery with cataract surgery. I think people that I've trained with have all been a little bit sort of shied away. I trained with Prof King and Prof Vernham in Nottingham, and they sort of were one of the ones that did this seminal article about trabeculectomy and phacotrabs that don't work as well. So I suppose that I'm a bit biased in that way. And I think that recently, with the onset of the minimally invasive glaucoma surgery procedures, we can, if the patient has a cataract, then we can do a cataract surgery with a mixed procedure. And it's not that the mixed procedure is going to replace the filtration surgery. It's not. But it will give you some time for you to do your cataract. It will bring the pressure down, and it will reduce the number of drops, IOP lowering drops that you're using. And therefore, will actually make you, or make the patient have, a much happier conjunctiva. And that will actually work in many ways. It will work in a way that you'll do a phaco mix and you get the patient vision better. You actually lower the number of drops and the pressure, and you buy yourself some time. And I usually say to patients when I see them for the first time, when I'm managing the glaucoma, I act like a financial advisor. I'm not looking at the short term. I'm looking at the long term. So I told them, I usually tell them, I'm looking at you for the next 30 years, and I need to play my cards right. So I need to extend all these surgeries, because we know that trabeculectomies fail, we know that tubes fail. So we need to sort of extend that treatment and delay these filtration surgery as much as possible, as long as we've got safe pressures.
Abaida, do you do the same for angle closure? Do you do, nowadays, we're just following the eagles, so that I go personally for chronic angle closure, I go for a lens removal, especially for patients if they are, above 40. And then I do usually something plus something if the optic nerve is severely done, whether GSL or cyclophotocoagulation. But definitely, I don't do phacotrabeculectomies because they scarred a lot.
Yeah, I have very good results with the eye stents on angle closures, and I'm also having very good results on viscocanaloplasty.
Interesting. That's interesting.
Yeah.
Yes.
Thank you. Thank you, Dr. Ricardo Rahman, for this comment. But this is here, you usually cannot apply this here in the Middle East. For example, this is any patient is if the patient with angle closure and IOP is more than 30 or 40 in full anti-glaucoma medication, this is 100% will not benefit from phaco.
Yes.
In this case, you cannot. This is the cataract, also the anterior chamber shallow. You cannot go. This is according to any study. So this is can go for trabeculectomy and can wait more than 6 months to increase the successful rate for the trabeculectomy. In this case, you 100% you should go for cataract. But also, if you go for cataract on very high IOP, you didn't have any chance. You will lose the eye, because any spike from IOP, you will lose the eye. In this case, we didn't prefer combined surgery, but this condition is 100% indication for combined surgery. Otherwise, you will lose the eye. This is here the issue.
That is true. There are occasions where you have to bite the bullet and have to do it. Yeah, I agree.
It seems that we're having different experiences regarding this, because you know that the chronic angle closure glaucoma is still an evolving issue and still you need to compare like trabeculectomy with phaco GSL. But definitely with advanced disease, you do something with phaco. I do something. Nowadays, we are comparing the different cycloablative techniques, or getting good results, or still collecting those results. So it's a very hot issue all the time, actually. Abaida, you would like to say something?
Yes. First of all, I just want to say, Professor Ahmed, that was a phenomenal talk. So many, probably that took you many years to put that talk together, but I think it just highlights just a few things to us. Number one is record all your surgeries. You never know when you're going to get a surprise, when you're going to discover something new. I think that's a really, really important point. We're always learning. And I think that's what's beautiful about glaucoma is that, particularly at this time, I think, is that we're, you know, every day is an interesting day. The second comment I wanted to make was I was pleased to see that you discussed about, you know, chronic angle closure glaucoma and a little bit about sort of non-ophthalmic eyes and such, and aqueous misdirection. I think it's really important at this point to highlight to everyone as well that, you know, 50% of patients, you know, you can treat them medically with topical antihypertensives, you know, anterior zonulo, anterior hyalodotomy, and the anterior chamber does deepen, as we saw in your case, fortunately, alhamdulillah. But 50% of patients, but 100% of patients, and this is evidence-based, will need to have surgical intervention definitively in the form of anterior vitrectomy. And I've not only seen this in Barvelt tubes. I had a case of aqueous misdirection as well with a Barvelt tube, but also with a PRESAFLO. As you know, I've got quite a big experience with PRESAFLOs, and I had a 72-year-old lady, myopic lady with a background of Stickler syndrome, who I put a PRESAFLO in, and she unfortunately developed aqueous misdirection. Fortunately, it wasn't an only seeing eye as in that case, but she needed prompt vitrectomy. And it's important as well to remind ourselves that in such cases, when you see a shallow AC1, you need to determine where is the shallow AC? Is it centrally? Is it peripherally? Is it both? And if it is both, you are not going to fall into the trap of putting in pilocarpine, which will definitely make things worse. Your approach to this is a mydriatic cycloplegic, followed by topical antihypertensives, and then seeking definitive treatment and onward referral. In terms of chronic angle closure patients, whether we go for tubes versus trabs, I think a lot of people are quite polarized about this. Ricardo's in the UK, but I have never met him. I'm from London and have been trained in London, and Ricardo seems like he's trained up in the north in Nottingham. Paul Foster from Moorfields used to say, you know, I would never ever do a trabeculectomy in an ophthalmic eye. So you do have different schools of thought. I don't think there is a right or wrong answer. I think you know, explaining to the patients the increased risk of complications of aqueous misdirection, of suprachoroidal hemorrhage, you know, we sometimes take it for granted the trust that's placed upon our shoulders, and in only seeing eyes, you know, the stakes are extremely high, just like they are in refractive surgery when you're operating on completely normal eyes, and you can have quite devastating implications. So those are just a few points I wanted to make. I also wanted to agree with Ricardo in the sense is that I have when it comes to aqueous shunt surgery, I don't put a supramid in, I put a 3O-proline in, and I put 2 ligatures around it in the form of proline. Previously, I used to put a vicryl in at the distal end, and then a nylon on the proximal end, making sure that it kinks the tube around the 3O-proline whenever I take it out, or whenever I do the argon suturolysis for the proline and wait for 6 to 8 weeks for the capsule to form and to have some form of resistance, because that's where you get the hypotony, and that's where I expect the case of hypotony and sudden suprachoroidal hemorrhage happened with Dr. Basil, which I'm very, very, very sorry to hear about. But that's the risk that we take by being doctors and sight-saving and life-threatening people and members of society. I just want to say from my side, that's all I've got to say. Thank you so much for organizing this fantastic meeting. I'm very grateful to learn from you every week. Thank you so much.
Thank you, Abaida, for your nice
Dr. Mazen, I just want to thank you very much, Basil, for your mentioning on the suprachoroidal hemorrhage, because I think there is no age that's immune against suprachoroidal hemorrhage. And I do remember, unfortunately, a baby who was like 2 months old, and he was referred with aphakic glaucoma, and the pressure was 40. And then I was, at the time of the operation, once the eye was opened, the baby develops suprachoroidal hemorrhage. So that again, it is the no age is immune, and it's the magnitude of reduction that happened in the intraocular pressure that could predispose anyone, and that's why that was the comment of Ricardo, that a place anterior chamber maintainer if you're dealing with an aphakic eye, because aphakic eyes are in particular, they're just putting you at the maximum stress at the time of opening of their eyes. Thank you, Basil, on commenting on this.
Thank you. Dr. Ahmed, regarding chronic angle closure glaucoma, one of the things I'm doing regularly for them to do a gonioscopy with a Zeiss lens and to do indentation and to see if the angle will be opened with indentation or not. This will give me a picture or to put in mind that if is cataract surgery will be enough alone to prevent future attacks of closure angle, or I have to share the or to combine the surgery with something more, as we mentioned, valve or maybe a cyclodestruction procedure or yet trap. So I think indentation will be helpful for us to see if it's and there is a synechia closing the angle, or it's just the iris root is against the trabecular meshwork and it's opened by indentation.
Thank you very much. Actually, my question about the angle closure is that it's not only the eye is problematic; it's also the orbit. Because the orbit is very shallow in some patients, so there is a technical difficulty in placing the implant. It is not just the eye.
Yes.
Can I comment about this for Dr. Basil? Gonioscopy, this is mostly is not give a good idea about this is the prognosis on what we can decide, because before the surgery, I should decide I start as with phaco or combined. In these cases, for that, I think the best solution is what is the medical effect for the medication. For this is as example, come for you the patient with 45 IOP. Sometimes this patient, when you try to make gonioscopy with indentation, the eye is very hard. Also, you cannot push the iris to see if it's totally open or not all sufficient. The best effect is this is the medical effect. If you give the maximal therapy and you find this is the decreasing in the IOP more than expected from the medical effect, in this case is the best way to know in this case is very good for phaco, not for combined surgery. Many of this patient, if you also try with mannitol, sometimes find the IOP 45 after medication directly go to 18, 20, 15, 20. This is very good indicator. This patient will benefit from phaco alone. But this group of the patient, if you give the full medication and after that find the IOP 35, I think this will not be benefit also from phaco. And this is an indicator, at least for me, to go directly to start with combined surgery if the patient has significant cataract.
Sure. No, Dr. Ali, just from experience, because we're having lots of those patients in Egypt. So that their everyday surgical list, we have patients with chronic angle closure glaucoma, and whatever the level of the intraocular pressure is, what I really do for them, just phaco or phaco goniosynculitis, I open the whole nasal angle, or phaco and cycloablative procedures, but I really don't do combined procedure. And you know, most of those patients are having a kind of qualified success, so that you are putting them in whatever the level of the preoperative pressure, so that it is just another point of view in managing those patients.
You mean this is micropulse or?
I'm comparing all the techniques at the time, including the endoscopic cyclophotocoagulation. Let us see. I'm just recruiting patients, but the initial observations is that they respond very beautifully to the cycloablative procedure, but you have to control the inflammation postoperative. So that's why I'm within those eyes, I inject long-acting steroids at the conclusion of the surgery to just wash the eye. And at the beginning, I used to get some membranes, and those membranes are decreasing gradually in intensity. So that let us see, I think I cannot have a final conclusion, just impression that they are responding nicely, actually.
Thank you very much. Thank you very much. We have just 2 minutes to conclude. So if any comment, very quickly, please, because now it's the time. So any comment, just within 2 minutes, please.
Only to avoid any exposure, this is one word, to avoid any exposure when you make any photoblast over the tube. It's better not to make edge between the cornea and the conjunctiva. Make the photoblast come smoothly on the eyelid to move very smoothly from the conjunctiva to the cornea. This is my comment, one comment.
Thank you. Basil, a quick comment.
In every valve tube surgery, please be ready for any surprise. I'm now doing Dr. Ahmed technique by doing a 3-tunnel to cover the tube, but sometimes you may face something unexpected, so keep the sclera graft patch ready. That's what happened with me today. I plan to do Ahmed valve for one patient. She is uveitic glaucoma. She has scleroderma, and I decided to do a 3-tunnel procedure to insert the tube. But after dissection the conjunctiva, I really astonished when I see the sclera. It was very, very thin, and I put the tube over and I covered all by a sclera graft patch.
So,
and I
so
really
always
happy
keep
to have.
plan B. So always keep plan B in the pocket ready to use.
Yes.
Ricardo, any comment?
Hello. No. I think the only thing that I would like to say is that I do not advocate doing trabeculectomies on a non-ophthalmos. Definitely not. I say that trabeculectomies did work very well for me in primary angle closure eyes, but non-ophthalmos, you certainly. I think I remember a lecture from Prof. Foster saying that the best operation for a non-ophthalmic eye is no operation, and you only operate on it if you can. So yeah, definitely. But if you do, use the tube.
Great. Thank you very much, everybody. Thank you, Professor Ahmed Mostafa, for the great session, and great thanks to Ricardo, Ali, and Basil, and as well Ubaida, who left us a bit early. So really, your contribution was so great, and we learned a lot from all of you, and hope to see you in the near future and future sessions. I'd like to thank the audience who stayed with us until now, and have a good night for everybody.
Thank you very much, Dr. Mazen. Thank you all. It was a great pleasure and honor. Thank you very much.
Thank you.
Thank you.